I'm happy to share some of our results from the U.S. Myeloma CAR-T Consortium on patients who received ide-cel or Abecma in the standard of care practice setting. Last year we've already heard outcome of close to almost 200 patients who were infused with ide-cel in that setting. So this year we delve into the details a little bit more, knowing that the manufacturing and turnaround time for ide-cel often required that these patients needed some type of bridging regimen while their CAR-T cells are being made, and trying to see if there's any associations with different types of treatment that patient might have had that might be associated with a better or worse outcome after CAR-T treatment. Now, granted, we have to take these results with a grain of salt because there's obviously a lot of confounding variables that goes into this type of retrospective analysis. There's a lot that goes into the bedside decisions between the clinician and the patient in terms of their underlying myeloma risk factors, what they have had leading up to the CAR-T treatment that may impact the decision for the selection of therapy. But we did see a suggestion that, certainly patients who didn't need bridging treatment did a little bit better than patients who did get bridging treatment. But certain types of bridging treatments, such as those that were more, monoclonal antibody based, IMiD based, rather than proteasome inhibitor based, seems to do better, seems to be a little bit more comparable to patients who didn't need bridging treatment. Now, whether that's a role for the bridging treatments or some of the underlying biology of the disease, we won't be able to tease that out with this analysis. But this suggests some information to hopefully help us design future prospective study to really look at, are there opportunities to optimize the patient's clinical status or the immune status, going into CAR-T treatment to make the CAR-T potentially work better.